Good morning, everyone. Happy to see everybody this morning and welcome to MGFA's Southwest Regional Conference. Our volunteer organizers today are Kim Vigil and Jennifer Case. We do want to thank our sponsors for the support today: Alexion, Argenix, Immunovant, UCB, and Horizon. Our agenda today is going to be, we are going to do a few welcome and introductions. And then Dr. Chrisman will be speaking to us about new treatments for MG patients. And then we'll have a Q&A. And if you would, please put your Q&A questions into either the chat box or the Q&A box, and we will get to them as we get to the Q&A portion. Then we will have Myra, sorry, I spelled this wrong, talking to us about exercising with MG. And then again, we'll have a Q&A discussion, and then we'll have some explanation of our support group schedule in the Southwest. I don't know if I introduced myself, but I'm Dova Levin from the MGFA, and I'm the Senior National Director for Patient Programming and Education. So I am going to turn this over to Kim for an introduction.
Can you go back a slide?
Yeah.
There you go. Thank you. So today our first speaker is Dr. Christina Chrisman. She is a fellowship-trained board-certified neurologist and neuromuscular specialist. She currently serves as the Medical Director of Neuromuscular Medicine and EMG at Banner University Medical Center, Phoenix, and is an Associate Professor of Neurology with the University of Arizona College of Medicine. Dr. Chrisman completed a fellowship in neuromuscular medicine at UCLA and Cedars-Sinai Medical Centers in Los Angeles, California, and completed a residency in neurology at Barrow Neurological Institute in Phoenix, Arizona. She is a graduate of the Indiana University School of Medicine in Indianapolis, Indiana. Prior to her medical training, she graduated magna cum laude with a BS in biomedical engineering from Rose-Hulman Institute of Technology, the #1 ranked undergraduate college of engineering in the United States. Dr. Chrisman has presented at national conferences and has various publications in nationally recognized neurology and neuromuscular medicine journals. Dr. Chrisman's outpatient practice focuses on patients with neuromuscular disorders of all varieties, with myasthenia gravis being a special interest. She enjoys teaching residents and students, serving as a neuroscience course director for first-year medical students at University of Arizona. She's proficient in English and Spanish, and she enjoys hiking and yoga in her spare time. She is also a partner in care with our MGFA organization. Dr. Chrisman, turn it over to you.
Thank you so much for that introduction. And thanks everyone for joining me on a Saturday morning or afternoon, wherever you're coming from, and taking time out of your weekend. We're going to talk today on an update on treatments for myasthenia gravis patients, especially some new treatments which have come out. It's an area of my specialty, which I'm really excited to talk about because there have been so many developments within even the past few years and more that are coming. So just keep in mind, this is a broad conceptual talk. For any patients who are on the line, always discuss with your treating doctor, what might be options that are right for you. So with that, the overview of our talk today, I think it's important to understand the background of myasthenia gravis, the disease, the mechanism of the disease, how we think about it as neurologists, as well as understanding triggers for exacerbation of myasthenia gravis and other things from a patient perspective to consider when thinking about treatments. So it's important to think of all of these things before we jump into the treatments and to understand what new treatments are that have been coming out. So many of you on the call as patients will be quite familiar with some of the things, but we'll set this up as background. And then just an overview of some of the treatment options we'll talk about, starting with some things which have been around for a long time, but still may work very well for the right patient: cholinesterase inhibitors, steroids, oral non-steroidal immunosuppressants, IVIG, plasma exchange, thymectomy, and then newer targeted therapies listed here, which we'll jump into more detail on later. So first, we're going to introduce the neuromuscular junction. So this is really important in understanding myasthenia gravis, what causes it, and how the treatments are thought about. So neuromuscular junction refers to the connection between a nerve and a muscle. So when your brain wants to tell your body to move, the signal starts in the brain, travels down the spinal cord, out the peripheral nerves, and then it ends up all the way at the point where the nerve meets the muscle to finally tell your muscle to contract. And that's the neuromuscular junction. So we're showing here the end of the nerve or neuron. The axon is the wired part of the nerve. And then at the neuromuscular junction, there's an important neurotransmitter that comes across here called acetylcholine, or you'll also see ACH as an abbreviation. So when the nerve wants to communicate with the muscle, it releases acetylcholine in the neuromuscular junction. That acetylcholine binds to receptors on the surface of the muscle, known as acetylcholine receptors. And then that eventually tells your muscle to contract. So this is the part of what's going on normally in the body that ends up being very important in myasthenia gravis. And, the acetylcholine may be used up the more activity that we do. And so that may be important in understanding why in people with myasthenia gravis, where this is not functioning properly, the symptoms may get worse with activity. So what is myasthenia gravis? So it affects, of course, the neuromuscular junction that we just introduced. And it is an autoimmune disease. Autoimmune meaning the body is attacking itself. It affects about 20 people per 100,000 in the US. And the weakness that can occur from myasthenia gravis can be fluctuating. So when you have failure of the nerve being able to communicate with the muscle, that happens with myasthenia gravis, that we'll talk about in more detail in a moment, then the weakness may specifically fluctuate throughout the day. So, and weakness can happen at various locations in the body, as shown here on this little schematic. So if you have weakness in the eye muscles, that may manifest as droopy eyelids, double vision, or weakness of eye closure. Weakness in the throat and the jaw may manifest as slurred speech, trouble chewing or swallowing. And the diaphragm is a muscle as well that can be affected. So if you have weakness in the diaphragm, you can get short of breath. And then weakness anywhere throughout the arms, leg, neck can be difficulty holding up the head. It tends to be the larger, more proximal muscles of the body affected. And so if the arms are affected, it can manifest as difficulty with overhead activities, even activities of daily living, like needing to hold up your arm and comb your hair and brush your teeth. Or in the legs, trouble getting up from a chair, trouble using stairs. And how we think about myasthenia gravis as neurologists, we can break it up into different categories, and that's important for understanding how we treat it. So first, we may categorize myasthenia gravis as ocular versus generalized. So if you have ocular myasthenia gravis, that means the eye muscles are affected and only that. And ocular myasthenia gravis may be thought of as a more mild form. And the good news is if it stays only ocular for about 2 years, has a tendency to stay that way and not generalize. Whereas generalized myasthenia gravis, usually the eyes are affected in most people as well, but other manifestations as well. So the speech, the breathing, the weakness in the body, all of that can be seen in generalized myasthenia gravis. And I should say that just because we call ocular myasthenia gravis mild, doesn't mean it's necessarily mild for one individual, because certainly if double vision is so bad that you cannot drive, it can be quite disabling. But we do have classifications from the Myasthenia Gravis Foundation of America, class 1 through 5. And that's how we kind of rate how severe that patient's particular disease is, with 1 being just ocular, 2, 3, 4 is mild, moderate, severe, and then 5th is the most severe, which is something known as a myasthenia crisis. So that can happen when the breathing is so affected that it becomes a medical emergency, and patients may need to be intubated and put on a ventilator. So that's how class 5, MGFA class 5 myasthenia gravis is defined. And then within the classes, we sometimes call it a type A, which means axial, just means the limbs of the body or more affected, or type B, when we see the patients have predominantly bulbar or speech swallowing type symptoms. So with that background, let's jump into the mechanism of myasthenia gravis. So we already said the important part is at the neuromuscular junction, but we know a lot about what causes myasthenia gravis. And I think that's fortunate, and that's helped in development of new treatments when we understand this pathology very well. So basically, myasthenia gravis is caused by antibodies. So antibodies are a normal part of our immune system that is an immune protein that in normal circumstances helps us to fight off different infections. But in myasthenia gravis, there are autoantibodies. So they're autoimmune, they're harmful. The antibodies are leading your own body to be attacked instead of fighting off an infection. And these antibodies, there are different ones which have been discovered in patients who are purely ocular. They have a tendency to not have as many of the antibodies showing up on the blood test. For example, only about 50% of patients with ocular myasthenia gravis may have a positive antibody test. But in generalized myasthenia gravis, 85% of the time, the antibody we can find on a blood test is called acetylcholine receptor antibodies. So that logically makes sense with what we were talking about earlier. We have acetylcholine as the neurotransmitter, acetylcholine receptors. Well, these antibodies, acetylcholine receptor antibodies, bind here and cause an immune attack. Multiple different mechanisms occur, so blocking the signal, destroying the receptors. And then an important part of the immune system, which we'll talk about again later, is something called complement activation that happens when these antibodies bind. And that actually can lead to destruction of the surface of the muscle cell here, destruction of the membrane. But there are other antibodies which have been identified in myasthenia gravis. A couple of them are MuSK, muscle-specific kinase, and LRP4. And you can notice in this detailed diagram that lists all the different protein components of the neuromuscular junction, MuSK and LRP4 are on here. Agrin was another one that's being studied. So we think that, similar mechanism, patients may have antibodies which are attacking some component of the neuromuscular junction, which ultimately leads to impaired neuromuscular transmission, or the muscles not able to contract due to failure of the nerve being able to communicate with the muscle. And as patients with myasthenia gravis may know, in addition to weakness getting worse with activity, fluctuating maybe worse later in the day, there are triggers which are known to, in some cases, cause flares or exacerbation of myasthenia gravis. So if a patient is ill with infection of some kind, exposed to stress, as we all are at some point, surgeries, and there are certain medications to be aware of when you have myasthenia gravis. that are known to trigger exacerbations. So I always advise my patients to check on the MGFA website. There's a very helpful link about cautionary drugs, which should be avoided if you have a diagnosis of myasthenia gravis. And some of them actually are quite commonly prescribed. For example, some antibiotics that may be used to treat upper respiratory tract infections. So I always encourage patients, if you're being prescribed a new med for any reason, you can either just check with your neurologist, make sure that's okay, or make sure the doctor who's prescribing it to you knows you have a diagnosis of myasthenia gravis and that medication is not on that list. And then heat as well, which is difficult for us in the summer here in Arizona, is unfortunately a known trigger of myasthenia gravis as well. So getting into treatment considerations of the disease, now that we understand the mechanism, the background for what causing myasthenia gravis. So I put here a snowflake, and you may have heard of myasthenia gravis being referred to as a snowflake disease. And that's pretty true. It's not the same for any one patient, and there's so many things to consider. So first is the severity of the disease, and we think of kind of ocular myasthenia gravis in a class of its own, in that sometimes patients are able to just be treated with one medication or low doses of steroids, for example, which we'll get into later, and maybe not as aggressively treated because we don't have to. They respond to kind of the initial steps we would use for treatment. But if patients are more, have more severe disease, they have not responded to standard therapies, then we need to think about what else is out there. What are the side effects of treatment, side effects that patients have had to treatments in the past? What comorbidities does the patient have? So other medical conditions, for example, in a patient who's diabetic, using steroids, which are known to increase blood sugar, for example, may not be the best choice. In patients who are thinking about having children, childbearing patients that within the next few years that may be on their life plans, there are certain medications we would want to avoid in that case. And then always discussing what is the goal of the patient. So talk with your doctor, minimizing symptoms may be the goal, and it may be a very reasonable goal nowadays to have as very few or almost no symptoms of myasthenia gravis, which we refer to as minimal disease manifestation. And we can keep working on that. However, is there a burden of the treatment that the patient is aware of? So, for example, do you need to go to an infusion center, have IVs? Sometimes those things can wear on you. So I think it's important about balancing treating the disease versus what do you have to go through for the treatments. So with that, let's get into what treatment options there are. We're going to start with some which may be much more familiar to you all. So first is cholinesterase inhibitors. That's probably one of the first things if you get a diagnosis of myasthenia gravis that's going to be tried. So known as pyridostigmine or brand name Mestinon. Basically, this is just a medication that increases acetylcholine at the neuromuscular junction. So this is the neurotransmitter that needs to come across the neuromuscular junction, and the acetylcholine receptors in myasthenia gravis are blocking this point, while this medication prevents acetylcholine from being broken down and just increases this amount of a neurotransmitter that's available so that eventually it can slightly overcome the neuromuscular blockade. However, it does not do anything at all about, say, your T cells, which are an important part of the immune system that are becoming dysregulated. It does not do anything about the production of antibodies that are happening in myasthenia gravis. So it does not do anything about the mechanisms we mentioned to you earlier of complement activation, the antibodies actually attacking the receptors. So that's an important distinction, I think, to make, because acetylcholinesterase inhibitors are not disease-modifying therapy. They are temporary and short acting. One of the benefits of it, though, they are quick acting. So it can be really helpful, as a measure to get through the day, control your symptoms quickly. And as you may know, there are some potential side effects, usually sweating, diarrhea, and muscle cramps, because it's kind of stimulating acetylcholine elsewhere in your body. And part of that can be causing sweat. So it's a great option, of course, but keep that in mind that it's not a disease-modifying therapy per se. The options we do have, which are treating the autoimmune disease itself, first, of course, includes steroids, typically prednisone, which has a broad inhibitory effect on the immune system. Usually the effects of prednisone are going to be seen within a couple of weeks. Early clinical studies back in the 80s, for example, when this was first being looked at in trials, showed either remission or marked improvement in about 80% of patients. But we know that it's very important to taper to a low dose. So if we can, due to the potential side effects that are mainly seen with higher doses of steroids. So you all may be all too familiar with side effects of steroids. That may include weight gain, increasing blood sugar, putting at risk for diabetes, increasing blood pressure, hypertension, can lead to cataracts, glaucoma, bone loss, mood swings. So when we do have patients on high dose of steroids, one, we definitely need to try to taper, as quickly as appropriate to try to get on a low dose. And then also, if patients are needing to be on steroids for a long time, there's important monitoring that needs to happen for bone loss, such as doing like a DEXA scan, for example, getting regular eye exams. You can take calcium and vitamin D to try to help protect the bones. And then it is an immunosuppressant, so we want to make sure patients are up to date on vaccination so they're protected. And then oral nonsteroidal immunosuppressants. So these treatment options have been around for a long time. And there still is, I believe, a very strong role for these medications in treatment of the disease. The two that I've listed here that have the most detail describing them, azathioprine and mycophenolate mofetil. Cyclosporin methotrexate I listed on here, but these are not used as often, mainly due to one, either toxicity or teratogenicity. So we'll focus on the other two. So azathioprine, it actually has limited evidence. We always like to follow evidence-based medicine as doctors and look at double-blind, placebo-controlled trials. There's not that much that exists for actually either of these medications, but one of the theories is because the trials were not long enough to actually show that they worked for myasthenia gravis. So we know, for example, azathioprine, patients may need to be on it up to 18 months until seeing a therapeutic benefit. Mycophenolate, similarly, maybe a little faster, but about 12 months. So these medications, I think, are a good strategy in patients we know we're going to need to treat long-term and eventually get them off steroids. If they're not responding as well as we would like to steroids or needing higher doses or having side effects to the steroids, getting patients started on this to eventually transition them off is a good plan. So you may also hear these referred to as steroid-sparing agents for that reason. So there is important monitoring that needs to happen and just to be aware of when they're on these medications. So azathioprine, we need to check blood counts, liver function. There is a potential side effect in small percentage of patient causes kind of flu-like reaction. And if that happens, we'd usually stop it. So higher risk of malignancy, I always recommend patients who are on any immunosuppressant, just get your routine cancer screening to make sure we're monitoring you for this. The risk of malignancy that was seen in this medication, it was mostly in patients who were like post-transplant or had other autoimmune diseases, not necessarily in myasthenia gravis, but just to keep aware of. And we don't typically use azathioprine in pregnancy, but the data suggests teratogenic risk is low, but we don't always know. And then mycophenolate mofetil that is known to be teratogenic, so we definitely want to avoid this in pregnancy or patients interested in childbearing. And again, the limited evidence probably due to the long duration until onset of a medication. Potential side effects, some diarrhea, nausea, infection, of course, being a broad immunosuppressant, and it can lower blood counts, so we do want to monitor that. Plasma exchange, or PLEX, is basically a procedure that directly removes antibodies from circulation. So most of the time that we're going to use plasma exchange is when the patient is in crisis or impending crisis. So very severe, we need something that's going to act quickly. It's an emergency situation. So usually it's done under, when the patient's in the hospital, a temporary catheter would need to be placed, usually a central line, like in the neck, for example. The exchanges would need to happen over a few days. So it's similar to dialysis, but we're basically exchanging your blood, which has the harmful antibodies in myasthenia gravis, with plasma. And then the harmful antibodies are removed from circulation after several treatments. So the onset of this, it works very fast, within a few days. The effect can last for a few weeks because eventually you start producing the antibodies again if you have myasthenia gravis. But we do need to be aware of complications because this is an invasive procedure. Placing the catheter in the neck itself, for example, there's some risk of lung puncture or bleeding. The exchange process itself, we have to watch out for low blood pressure, low blood calcium, blood clots. There can be a rare infusion reaction from the plasma. And then if chronic plasma exchange needed to be done for long-term therapy, for example, that would require more permanent access. You may have heard about in patients who are on dialysis for kidney failure, for example, getting a surgery done called an arteriovenous fistula to actually permanently connect the vein and the artery in somewhere like the arm or the wrist. So that's rather invasive. I will say that chronic plasma exchange is not really done very often for all these reasons. IVIG stands for intravenous immunoglobulins. So immunoglobulins are protein antibodies. IVIG is from people that donate plasma. So these are antibodies essentially from other people. And we don't understand 100% how IVIG works in myasthenia gravis. It's a complex mechanism of action, but it basically helps to overcome the autoimmune disease. We use it for several autoimmune diseases to modulate your immune system to stop those harmful effects from happening, yet not being an immunosuppressant. So that's one of the benefits of IVIG is it doesn't really suppress the immune system. So we definitely use IVIG a lot for exacerbation. There is some good evidence. I mentioned here trials showing benefit. And the subset of patients who benefited from IVIG when their disease was moderate to severe. And we see onset pretty quickly within days to weeks. So that's why this makes it a good medication for a crisis or exacerbation, for example. What about as a maintenance therapy? So for example, if this needed to be a maintenance therapy, IVIG might be administered every few weeks, for example. Well, we do know it works for the right patient, but the evidence it is not as robust for something like this. In fact, recently there was a study just came out in 2023 trying to see if patients who were treated with IVIG over 36 weeks, as opposed to those who were not on IVIG, if they needed less steroids. So unfortunately, that endpoint was not met. But we do know, like I mentioned, that in the right patient, IVIG works. And complications are usually pretty mild, headache probably being the most common thing. And very rarely we have to look out for kidney injury or blood clots. Rituximab. Rituximab is one of the first targeted therapies that we're going to talk about here. So it's an engineered molecule. It's intravenous. And it is basically an engineered antibody that binds to CD20, and that's a marker on the surface of certain B cells, and B cells are part of your immune system that's important in producing antibodies. So a systematic review looked at rituximab in treating myasthenia gravis and led to minimal disease manifestation 30% of the time in patients who had acetylcholine receptor antibodies, but 72% of the time in MuSK-positive myasthenia gravis. So that's why in patients who have MuSK myasthenia, and their antibodies are a little bit different, they respond to treatments a little bit different, rituximab may be a good choice in those cases. The dosing regimen is a little variable. The most common dosing you would need is weekly for 4 doses, and then you could redose every 6 months. We usually see onset of improvement pretty quickly within a few weeks. And then, as I mentioned, it lasts for a long time, about 6 months. Side effects, we may need to be concerned about infusion reactions. So usually patients are monitored, at least for the first dose. And then this is an immunosuppressant, so we need to monitor patients, be aware that there may be severe recurrent infections. And usually we need to check some labs prior to starting on rituximab, for example, to make sure patients don't have a latent, say, hepatitis B or tuberculosis that we worry could reactivate if we start this treatment. Thymectomy. So what is thymus? So this is referring to the thymus gland, which sits here in the chest under the sternum. And this is an important part of the immune system, actually. So if you have something known as a thymoma, which is a tumor of the thymus gland, that should be removed. So hopefully all patients who are diagnosed with myasthenia gravis at the beginning should have some kind of imaging, chest CT or MRI, to look for a thymoma, because there is a high association with that tumor and myasthenia gravis. So definitely if there's the tumor of the thymus gland, that should be removed. However, there's also evidence for prophylactic thymectomy in people that do not have a thymoma. And this is based on fairly recent evidence of a study that was done in 2016. So a randomized controlled trial looking at people who were just treated with prednisone versus those on prednisone and had a thymectomy. And they did see that the thymectomy had benefit, but it was not immediate. So we're looking at, can we achieve a remission, or can patients reduce the doses of their immunosuppressants? We saw remission was only about 20% of patients after the first year, but over 7 to 10 years, 50% of patients may go into remission after thymectomy. So it's a long time before you may see the effects of this, and definitely in the right patient, it may be worth considering. It's important to note, though, that in the study, the benefit was seen in patients who are acetylcholine receptor positive, less than 60 years of age, most commonly generalized or very disabling ocular myasthenia gravis. And we should make sure the patient's myasthenia gravis is under good control, especially if we're going to undergo a surgery. Make sure you're not at risk for undergoing the anesthesia or anything like that. And in old days, when a thymectomy needed to be performed, it was a rather invasive procedure. You basically need to open up the whole sternum to be able to reach the thymus gland. But nowadays, less invasive techniques are being used, and this can usually be done endoscopically. So now getting into the part about newer targeted therapies. So hopefully I've been able to set up a good background for understanding kind of the current standard of care options that we've had, options that we had, let's say 10 years ago. That was about it. But a lot has happened within the past, say, 5 years, and even more to come. So you may hear a lot about these therapies: complement inhibitors, FcRn blockers, and then a few we'll get into later with even newer mechanisms of action. So first, complement inhibitors. So remember, we talked about a bit earlier in acetylcholine receptor positive myasthenia gravis, when the antibodies bind to the acetylcholine receptor, one of the parts of the immune system that gets activated is something called complement. So it's a complicated kind of cascade that goes on when complement is activated, but it ultimately results in the membrane getting destroyed. In fact, this MAC that you see here, it's named membrane attack complex. So that damages the surface of the muscle itself. So complement inhibitors, they prevent a specific portion of this complement cascade to prevent the membrane attack complex from happening. So it works quite well. Both of the medications that we have that are FDA approved on the market right now are intravenous, so IV, and they are only for patients who are acetylcholine receptor antibody positive. So eculizumab was the first one. It was approved in 2017. It's dosed weekly for 5 weeks, and then after that, every 2 weeks. It's pretty short infusion, about an hour. And main side effects that were seen in the trial were musculoskeletal pain. And then ravulizumab came out in 2022. So it's basically the same mechanism as eculizumab. It was just engineered to have a longer half-life, a longer duration of effect. So when patients are on maintenance dose for ravulizumab, they only need an IV infusion every 8 weeks. So that's pretty convenient. And then side effects may include musculoskeletal pain, also seen in the trial were upper respiratory tract infection or diarrhea. So we definitely see improvement with complement inhibitors within 4 weeks of starting the medication. But I will say, if you look at the clinical trial data and even with experience of using these medications, is that it does start to work a lot faster that. So even after, say, the first infusion, looking at patients 1 week later, might already start to notice some improvement. But it is important to note that all patients on complement inhibitor medications need to have a specific vaccination called a meningococcal meningitis vaccine. So just because of how this medication works on the immune system, we need complement to be able to fight off certain types of bacteria. And one of those types of bacteria is a very serious, in fact, deadly type of meningitis called meningococcal meningitis. But the good news is a vaccine exists for that. So as long as patients are vaccinated, it does seem to be a very safe option as well. And finally, FcRn blockers. So this is a pretty unique mechanism of action. I will say even a lot of doctors have had to brush up on what does the FcRn do in the body, since it does now have relevance in treating disease. So FcRn, it stands for Fc, neonatal receptor. So Fc is basically the ending of an antibody. So the little stalk part of an antibody is known as the Fc component. And then neonatal, meaning this receptor was discovered as being important in mother being able to pass on antibodies to the fetus through the placenta. So FcRn receptors, so the antibodies, Fc component binds to the receptor. And normally in the body, this is showing you here a blood vessel, and then what's inside the cell, there's some antibodies inside the endosome. They're binding to this Fc receptor, and binding to the Fc receptor protects antibodies from being destroyed. So they're bound to the receptor, and then they get released back into the bloodstream. Well, in myasthenia gravis, we have harmful antibodies that are being released into the bloodstream. So the idea is, if we have a medication that binds to this receptor, then the antibodies can no longer bind to the receptor. And then more antibodies will be broken down and destroyed, and fewer antibodies being released back into the bloodstream. So this only works on a specific type of antibody called IgG. So other antibodies are not affected, which is good for your immune system. But your acetylcholine receptor antibodies, which are IgG, do get affected by this mechanism, which is what we want. So it acts kind of similarly to what we described plasma exchange did. The antibodies are directly removed from circulation. But the benefit of this is it's just a peripheral intravenous medication instead of needing to go through a more invasive procedure, for example. So efgartigimod is the current medication, which is FDA approved right now, that acts by this mechanism. It is only approved for acetylcholine receptor antibody positive myasthenia gravis. It is given in cycles. So the treatment for this is IV once a week for 4 weeks. That's one cycle. And then it can be repeated at an interval that's individual to the patient. So it depends how you do. This effect seems to be long lasting, but patients who still have myasthenia gravis disease eventually start to produce the antibodies again. So about the time that this effect wears off, if symptoms start to come back, another cycle could be repeated. So it depends. Usually the minimum time that we could repeat another cycle with this medication is about 4 weeks, but some patients, they may not need another cycle for say 10 plus weeks. It really depends. And then as side effects typically might include headache, muscle pain, slight lowering of white blood cell count, but pretty benign. And then the onset of this medication is pretty quick as well. So within that 4-week cycle, within a week or two, the benefit will start to be apparent. And then finally, mentioning here for you some things to look out for that are currently in studies. So I want to make a note, none of these medications are FDA approved yet. And this is not even an exhaustive list of everything which is currently being looked at for treatment of myasthenia gravis. But these are ones that are kind of in later stages of study. And so we hopefully will be hearing more about them soon. So, and just to give you an idea, a broad overview, we can't say too much about these yet, since there's still some information that needs to come out, but the types of things we're looking at, a complement inhibitor, which is subcutaneous. So all the newer targeted therapies we talked about so far are intravenous. Subcutaneous means either an auto injector or a pre-filled syringe, something similar to like an EpiPen patients may be aware of, that you don't need to travel somewhere or have a nurse come to your home to administer something IV. You can just administer it yourself at home on your own schedule. So that might be a benefit to some people to have a subcutaneous medication option. Same with FcRn antagonist that we talked about as a mechanism. A subcutaneous version of that is hopefully coming out soon. A newer mechanism of action that we have not seen before in myasthenia gravis, but is seen in treating another autoimmune disease called neuromyelitis optica, is CD19 B cell depletion. So specifically targeting a surface molecule on B cells that again are important in production of antibodies. Another IV FcRn medication that has administration every 2 weeks is being looked at. There's a unique mechanism of action complement inhibitor that's possibly going to be intravenous subcutaneous combination. It's a combination medication that has another component that acts on the production of complement in the liver. And then finally, IL-6 receptor blocker, which is very unique. We have not had before in myasthenia gravis. IL-6, for example, is a signaling molecule that's involved in both T cell and B cell dysfunction and activation. So very important parts of the immune system response, blocking that route. And it's a subcutaneous medication as well. So just to give you an idea, there's a lot of exciting things happening in the myasthenia gravis world. And even with all the exciting options we talked about we have right now, there's more to come. So with that, just wanted to mention treatment strategies. So again, every patient is different. Discuss with your doctor what you may be a candidate for and what your goals are. Because I do think something we refer to as minimal manifestation status is a reasonable goal. So that means, patients have myasthenia gravis, they're on treatment, they take medication, but other than that, they're not too aware of having the disease in their daily life. Manifestation of their disease is minimal, and that is a reasonable goal. However, we have to take that into account and balance with the potential burden of treatment. So having IVs or needles that often, for example, having blood work, monitoring, things like that, how burdensome is the actual treatment on the patient? So always consider, I think, both sides of the coin. And then remission. So inducing a remission in somebody with myasthenia gravis, that's always the ultimate goal. And that means having no signs of the disease and then successfully being able to come off all immunosuppressants. So hopefully we'll be seeing more and more of that as our options continue. So with that, I thank you very much for inviting me to talk to you all today, and I'm available for any questions.
Thank you so much, Dr. Chrisman. We do have a couple of questions. The first question is, when might you recommend moving from a complement inhibitor or FC receptor blocker treatment to CellCept?
Okay, sure. Thanks for that question. So I think, it's important to understand how those medications may work differently. I think it may be appropriate for patients to be on, say, both something like CellCept and one of the other therapies, like the FcRn blocker or the complement inhibitor. And many patients are on both because those things like CellCept, the non-steroidal immunosuppressants, they take so long to work. So oftentimes, if patients are started on that, we're waiting a year or more for that effect to work on the immune system. A lot of times we need to use something else to bridge them to that point when it's becoming effective. And then perhaps considering taking them off those other things, which are IV. So there's all different treatment strategies. Of course, it depends, but that's kind of the way I think about it.
Thank you. The second question is, can you speak to seronegative MG and the best treatments for improved results in those patients?
Sure. I think that's an interesting topic, and we're learning more about that as well. We've identified a lot of the antibodies that exist in myasthenia gravis, but we have not identified everyone. There is a very small percentage of patients who truly have seronegative disease. But I will say, when I have patients that are negative for every antibody that we can test for, I just want to make sure that we have the diagnosis correct. And in all those cases, I would encourage you to make sure that the diagnosis is proven by some other means, usually some kind of electrodiagnostic testing like single fiber EMG to prove that's what you have. Because there may be other things that are mimics, or some patients may have actually something like congenital myasthenic syndrome, which is a disease of neuromuscular junction, but it's not autoimmune. So always keep that in mind. One, we want to make sure diagnosis is correct. And then we know how patients with MuSK myasthenia respond differently to treatments. The ones who are truly seronegative, it's hard to say. It's hard to say how they may respond. We may try different things, but we don't have necessarily the evidence or guidelines out there. But we do know that they would not be candidates for some of the newer medications that have come out, which are only for acetylcholine receptor positive myasthenia gravis. But all the other things we mentioned can be tried. the steroids, non-steroidal immunosuppressants, even theoretically rituximab might be an option, but it really just depends.
Thank you. Someone said, if I understood the thymectomy flowchart correctly, is it appropriate for seronegative MG? And if so, under what circumstances?
Sure, let me see if I can get back to that. So yes, in patients without thymoma that are typically of the right age, if they are seronegative, and I would again encourage you to make sure the disease is proven by some other means if you're seronegative, but thymectomy could be considered. I do have many patients who did have thymectomy that are seronegative. So if you meet the criteria by other means, yeah, that might be appropriate in the right circumstance.
I have a piggyback question on the thymectomy. So if someone is diagnosed and they're considering a thymectomy, when your patients have the thymectomy, do you see that they have better results if they have that thymectomy within the first year of diagnosis, or does the timing have an effect on the outcome?
Yes, it does. I think in the trial it was it encouraged, at least within the first couple of years of diagnosis, to consider having a thymectomy. I do think that the earlier the better. That's correct.
Okay, thank you. Couple more here. If you're on a lot of current medications for other illnesses, what would you recommend to take or try?
Sure. So it really depends. Like I mentioned, in our things to consider with myasthenia gravis, all of these things here, right? What have you tried before? What are side effects potentially of treatment? So if, like you mentioned, you have other medical conditions, there may be certain things we want to avoid, like patients who already have kidney disease. We may want to avoid some of those things which are known to potentially affect kidneys. Or if you already have high blood sugar, high blood pressure, we may want to avoid things like steroids. So it's a broad, I can't specifically answer the question. There's so many things that need to be considered, but you're right. I think all the other medications that you're taking and all the other disease states really need to be considered when coming up with a plan with your doctor.
Thank you. We have 3 more questions if you have time. The first one is, current treatments like Plex and IVIG are so expensive. Is cost reduction one of the strategies for new treatments currently under study?
Yeah, that's a good question as well. So I think, I think, theoretically how I should be able to have a relationship with my patient is, let's come up with what is the best option for you and not have to consider cost, right? But unfortunately, that is not how medicine works, that the cost may be passed on to someone. So hopefully with all of these options, if patients have insurance coverage and there are patient support programs that may be sponsored by the companies that make the drugs, that the cost to the patient is not too expensive. However, the overall health care cost, it is higher for a lot of these therapies. A lot of development went into making the therapies, and so companies have to charge more money to try to recoup. So it's a very complicated and probably topic for another day. But yes, I definitely think the cost of treatments should be considered. Hopefully, as more options come out, there's more competition and costs come down. But I hope it's not, necessarily something that the patient has to think about.
Thank you. Can you speak to the impact of diet on disease exacerbation?
Sure. I think that not necessarily any specific diet has been recommended or looked at in clinical trials as far as preventing disease exacerbation. However, we do know in some patients that they get a lot of symptoms in their jaw, like from chewing a lot. Then certain types of things may make that harder. So usually like meat and tougher things can be difficult to chew, and you may have to adjust, to softer foods if you're somebody where that's a symptom. although that symptom may be treatable if you discuss with your doctor what other things can you do to try to get your myasthenia under better control. But as far as a specific diet, nothing that we have any evidence for.
Okay. And the last question, it is often stated that MG symptom progression after 3 years is generally minimal. How concrete is the observation from your experience?
So I wonder if we're talking about the possibility of ocular versus generalized. So that is true, that the rule of thumb, if the patient starts with purely ocular myasthenia gravis and it stays that way for about 2 to 3 years, then it usually does not generalize. That is the rule of thumb. But as far as how does the disease progress? I think it depends on a lot of things. I think we will probably be in a better situation if the patient is treated appropriately early on, and that way the immune system doesn't get a chance to start, going into a vicious cycle. That's one theory on why we treat myasthenia gravis early and effectively. However, I do have patients who've had myasthenia gravis for many years, and it can flare up, for all of these different reasons, surgeries, taking a medication, going through infection, getting worse during the summer. We do see that from time to time, but I think you're right. It's important, especially when it's first being diagnosed, to make sure you're treated adequately to try to prevent that.
Wonderful. Well, thank you so much, Dr. Chrisman. It's very informative and we appreciate your time.
Thank you.
Did you want to mention this, Kim, as well?
Sure. So Dr. Chrisman had shared that Banner Health has an MG blog. And so here's the link. We can make sure that this is sent out to all of our participants today. And we'll make sure that this is on our page. But there's a lot of good information on this blog that you may be interested in checking out.
Thank you. Okay, Jennifer, you are up.
Good morning. So Myra unfortunately had a family emergency today, so she was grateful enough to pre-record our session today. So unfortunately, we won't have a live question period, but if you do have questions, we can give those back to her. So Myra is an exercise physiologist who works closely with multiple disciplinaries teams with the wellness clinic at Honor Health and Neurology. She received her Bachelor's of Science in Exercise and Wellness from the Arizona State University. She is a personal trainer for adults with disabilities during her undergrad. In addition, she has a comprehensive knowledge of massage therapy and creates home exercise programs and rehabilitation care settings. Her passion for wellness began as a therapeutic massage therapist, where she acquired the knowledge for enhancing wellness into people's lives. So if we can start the video. Can everyone hear her?
No.
I don't hear any audio.
It's on, the audio's on. I'm not sure why it's not coming through. I hear it from my end, so let me put my computer not on mute, and maybe we can hear her through my computer. Hold on one second. I want to make it a little louder. Anything now?
No,
I think
I
she's
don't hear anything.
paused.
No,
Nothing.
Hold on. Okay, I'm going to start sharing again. Sorry, everyone. Let me just try this one more time.
Still nothing.
no,
no audio, none.
Okay, I am sorry that it is not going through. I don't know what I can do at this point. I think what we can do is send out the recording to everyone and let you guys watch it on your own time. But what I'll do is share my other screen so that we can talk about the support groups, and I will let, hold on one second. And I will let Kim take over again and talk about our support groups in the region. Kim?
Can you, so yes, we do have, yeah, if you can, there we go, the slide. So we have quite a few support groups nationally, as many of you may know. Here in Arizona, we have a East Valley group that I typically lead along with Joan Monroe, and in Tucson, Jean Casagrande, and Southern California is Connie DePasquia. I hope I said that right. For the Arizona East Valley, they are the last Tuesday of the month at 5 o'clock, and I have those calendars scheduled out through the rest of this year. It is 5 o'clock Arizona time, so for those of you that may join us outside of Arizona, we don't change time. So half the year when it's daylight savings time, we're Pacific time, and half the year we are Mountain time. So you want to make sure you check that time, but it's 5 o'clock Pacific essentially until the time change in the fall, and then it goes to 6 o'clock Pacific in the fall. Jean and Connie's, typically they're listed on the MGFA website under the support group link. And if you are a part of their group, you may get those emails. And if not, you can always check the website, or you can reach out to us via email, and we're happy to send you the next meetings that are coming up for our Southwest region.
Great. Well, I appreciate all of you being here today. I am sorry that the recording didn't play. We will send it out just right after this to everyone so you can watch it. It is a nice video, so we hope that you all can watch it and send us your questions, and we'll get them to the speaker. So does anyone have any questions before we end for today? All right, well, thank you very much for joining us, and we will hopefully see you all soon. Thank you.
Thanks, Tova.